So I will talk today about right coronary artery engagement, and I will give also some details about how to maneuver one of the most important catheter in interventional cardiology, Amplatz left. I have provided right coronary artery talks in the past, and I suggest you review those under my YouTube playlist, Cardiac Catheterization Technique, particularly that one here. But each time I try to use new different cases and updated diagrams and ideas. So we have different illustrations and different cases every time. Today, I will show details of right coronary engagement and troubleshooting for the new fellows, but I will also show more advanced ideas and cases that are useful for more advanced fellows and even interventional fellows. Including a description at the end of Amplatz left and of guiding catheter for right coronary engagement. Okay, so I will start with basic ideas about right coronary engagement. So the first basic idea is when engaging the right coronary artery, we start by putting the catheter, typically here Judkins right 4 catheter, we put it on top of the aortic valve, we touch the aortic valve, the right cusp of the aortic valve. Then we pull with a clock maneuver. It's a simultaneous motion of pull and clock about 90 to 180 degree to make it move from left looking to right pointing. Okay. That's the maneuver that applies for both radial and femoral. And this is, like I explained in the past, this is how we torque catheters for coronary engagement. Both your hands are on the catheter. One is on the front, one is on the back. And both hands do that torquing maneuver 90 to 180 degrees as you're pulling the catheter. You want to see that torque being transmitted as you're torquing it. You don't want to see that torque getting stored. If you torque in place and you don't see anything happen, then when the torque gets transmitted, you'll end up with a catheter doing 360 degrees and going back in place. So you want to see that catheter moving as your hands are moving. Otherwise, you'll get stored torque and very swift transmission into 360-degree torque at some point, okay? Another basic idea, and I want you to know in this first idea, I always tell fellows, so the right cusp for right coronary engagement, the right cusp is our base of operation. Whenever you get lost, whenever the catheter flies up or down, you get lost, get that catheter back onto the aortic valve and specifically onto the right coronary cusp. This is your base of operation for coronary engagement. Okay, another basic idea here is the difference between radial and femoral. In both radial and femoral, we touch the right coronary cusp and we pull with a clockwise torque maneuver. However, from a femoral axis, the catheter tends to dive a lot more than it does from a radial axis. From a femoral axis, it tends to dive down. From a radial axis, if anything, it tends to be pulled up too much as you're pulling on it. So that's why when you're engaging from a femoral axis, you have to keep a stronger pulling tension on the catheter than you do from a radial axis. And I find that fellows have harder time engaging the right coronary artery from a femoral than from a radial axis because you need to keep that pulling tension and prevent the catheter from diving down. And as I explained last time, while radial axis elongates the catheters when they are looking to the left, it actually shortens and loops the catheters when they are pointing to the right. So you don't need a shorter catheter when in radial axis RCA versus femoral axis RCA. So we use the same catheters, radial and femoral, when in terms of RCA engagement. We use, for example, Judkins right 4 and Amplatz right 1, 2. Those are the standard catheters we use from both radial and femoral. Those are the catheters. So this is the standard Judkins right 4. We almost always use Judkins right 4. We very rarely use Judkins right 5, unlike in the left, Judkins left, where we frequently use the whole spectrum, 4, 5, even 6, and 3.5. All right, this is the Amplatz right I described last time. It's a duck-shaped catheter, as opposed to the Amplatz left catheter, which has a large butt sitting on the aortic valve and the opposite aorta. Amplatz right has a small butt, and it doesn't sit on the aortic valve. So it's a lot less supportive than Amplatz left, but it's easier to maneuver, and it's easier to engage the right coronary with it, and it's safer. Amplatz left, which I will describe later, is a sort of a universal catheter. You can use it for the left, but you can also use it for the right coronary. Amplatz right is exclusively for the right coronary. You can also use the Tiger and Jackie catheters from a radial access, and those are catheters that can be used for left and right coronary artery from a radial access. Okay, now I will, after describing some basics, I will dive into more of the details, actual details of how to engage from a radial access. So those are the steps of RCA engagement coming from a radial access. So the initial steps are similar to what I described last week with left coronary engagement. So you advance a wire all the way up onto the right coronary cusp. The wire will often fall when you come from a radial access and even femoral access. The wire will often fall onto the lower cusp, such as right or non-coronary cusp. They don't often fall onto the left cusp. That's why when we want to do left engagement, as I explained last week, we need to have a jump into the left cusp. Anyway, so our wire will fall onto the lower cusp. And in your brain, you always imagine lower cusp is right or NC, higher cusp is left. So you have to always imagine in your brain as you're engaging and maneuvering right cusp, left cusp. Okay, you always draw it in your brains. Anyway, so your wire falls onto the right cusp. Then over it, you want to advance that Judkins right catheter. Now, it's exactly like we do with Judkins left. As you're advancing the catheter, you want it to look to the left. Even if you eventually want to engage the right, you want that catheter not to be looking and rubbing that convexity of the aorta. If you advance it this way, it may prolapse everything out, as it happens with the Judkins left. So you advance it, and as you're advancing, you ask the patient to take a breath, and you try to slightly clock it to make it look this way. So you advance it, and you make it fall onto the right coronary cusp, looking this way, over the wire, and you reach that base of operation, the aortic valve coronary cusp. After that, in this case, you can pull the wire, unlike with the left coronary engagement. You can pull the wire, then you do this. You pull with a 90 to 180 degree clockwise maneuver to engage. Again, you make it look to the left, then you pull with a clock to make it look to the right. You're not going to engage by pushing it in this orientation and hoping it will fall onto the right coronary. You have to start here and pull with a clock. It has to start by looking like this. You may get lucky at times pushing it in this direction and falling in, but it's rare. Okay, so this is an illustration of some cases. Here the fellow was pushing down. Unlike what I was describing, he was pushing it down with the catheter. Look at the catheter, looking toward the convexity of the aorta. That's not what we should do. As he's pushing, he should torque it a little bit, usually clock, to make it look into this direction, before you eventually pull and clock. The wire, notice, is onto the right or non-coronary cusp. And always imagine, always in your brain, make this illustration, okay? And imagine the convexity of the aorta. Now, this is another case, very common case here. So let me start it over. So we fell onto the right cusp, and here the fellow pulled with a clockwise maneuver. He fell lower than the coronary. So he pulled the catheter straight. He ended up higher than the right coronary. See, he pulled straight, he ended up higher. So he started lower, he fell lower here, then he pulled it straight, he ended up higher. His aim was to get here. So we got here, then pulled straight, got there. So several questions here. One, how do you correct for this? This is a very common phenomenon where the catheter ends up being torqued and looking below the right coronary. How do you correct for this phenomenon? And that's one. Two, how do you recognize you're below, you're above? That's usually confusing for early fellows. So one, the way you recognize whether you're low or high is when you give a puff. When you give a puff and you see this nest, that pocket here, bird's nest, this is a sinus of Valsalva, you're below the coronary. The coronaries arise typically at the top of the sinus of Valsalva. So between the sinus of Valsalva and the convexity of the tubular aorta. So when you see the sinus of Valsalva, usually you're low. When you see the convexity of the aorta, you're usually high. And I will show some more pictures. So that's one, how you identify you're low or high. Two, how do you get from this to this? I'll tell you, it doesn't work to just pull the catheter. If you come low and you just pull the catheter, it will fly up, as has happened here. There is finesse to get from this to this. And this is how we get from this to this. You don't just pull. So you've clocked from here to get here. What you do, you reverse your torque. So you counterclock a little bit to make it look a little toward you. Then you clock again. So you counterclock and pull to raise the level. Then you clock again to get into the coronary. Okay? And this is a standard maneuver that you should know how to do. And here is an illustration of that. So here again, the fellow clockwise torque and pulled, and the catheter came in the sinus below the coronary ostium. And on the non-selective puff, you can see that nest, that sinus of Valsalva. So he counterclocked, slightly counterclocked. The catheter is looking at us, then pulled with a clock, and he fell in. You see that? So he did a perfect maneuver here. This is one of our fellows. So counterclock, then pulled with a slight clock, and he got in. Again, practice always imagining those cusps in your brain. And this maneuver is done with any catheter, whether Judkins or Amplatz right or Tiger, but it's easier with Amplatz right than with Judkins. I find that torque gets transmitted easier, especially in fellows' hands, with Amplatz right than with Judkins right 4. Okay? And this is my answer to the other question. How do you know you are too high or too low relative to the RCA? So it's non-selective path. If you see the nest, you are too low. If you see the convexity, you are too high. Okay, this is another illustration here. And again, you can see here, I want you to recognize that on the non-selective path, you see that sinus of Valsalva, you see that nest, you're too low. Again, the catheter has been clocked and pulled, but it came too low. So this is what was done here. It was counterclocked slightly and pulled gently, and look, it nicely engaged. So usually you counterclock and pull, and usually with a little clock, and you engage. And here another important idea for you. So we counterclock and pulled, and we engage. Okay, let me show it here. So we engage, we're in. But it's kind of not coaxial. So in the right coronary, when you want to get deeper, when the catheter is looking at you and it's not coaxial with the artery, you can clock it here, and the catheter will become more coaxial and more stable. So a lot of time to get a better, deeper engagement of a right coronary catheter, even if you're in, but you want to get better in, you can do further clock to get more deep-seated and more coaxial and more stable in that artery. Okay. Another idea is once you've got in, and let's say you are somewhat coaxial, one thing that applies particularly to radial is that the catheter tends to be very unstable, meaning you get in, but the catheter will tend to fly out, especially with your injection. So once you get in, you have to push the catheter. If you're not coaxial, clock it. If you're coaxial, just push it so you get more stable engagement, particularly with the Judkins right. So here, he didn't push it and the catheter flew out quickly. So what you do, you have, after you get engaged, you push it a little bit to have more stable engagement. Otherwise, it will quickly fly out. So that's another important idea. Okay. So this is an illustration of what I just described, how to get when you're coming too low, how to get in, and that very last step where you push it to get more deeper and more stable in. Now, what to do when the catheter comes too high? Okay, so you clocked and pulled and the catheter came too high. That's another very common situation, especially from a radial access. So in that case, you reverse your torque. You don't just push it down. Again, my idea here, don't pull and push when the catheter is looking in this direction. If the catheter is looking in this direction and it's not into the RCA, you have to reverse your torque. In this particular case, when it's too high and you're puffing, you see the convexity, reverse your torque, meaning counterclock, and push back down to the nest and restart over, clock and pull, okay? Another interesting idea is try to imagine the aorta in general as you're trying to engage left or right coronary. Imagine how the aorta is. Beside imagining the cusp, the most important thing is to imagine the cusps as you're engaging, right or non-coronary and left coronary cusp. Another thing to try to imagine is the shape of the aorta, relatively straight in a younger patient versus elongated, very elongated and becoming horizontal at the heart level in an elderly patient or patient with dilated aorta. Because it makes a difference in engagement. When the aorta is elongated, the distance from the aortic valve to the right coronary artery is the same, regardless of the shape, but the vertical level is different. Here, the vertical level of that right coronary artery will be a lot lower than the vertical level of the RCA in this patient. The RCA will seem displaced more downward and is pointing more downward than usual here. And the way you can tell the shape of the aorta is from the shape of your catheter. How the catheter is looking is how the aorta is. So this is an example from this week. So this is a patient with a 5.5 centimeter aorta. So the fellow he's trying to engage here as if the aorta is like this. He's aiming way too high. I knew he's not going to engage it with this. So, and by the way, this patient has AS. So you see the AS jet hitting the catheter, making it dense. Anyway, so he came way too high. So the way we engage it is like this one. So we knew the shape. So we aimed to pull and clock from this position, knowing that the right coronary artery will be here, very low and looking down, and it worked. Look at this. So we clocked and pulled, and we ended up being in. This was way too high here in the convexity of the aorta. This is just a quick slide about clock. Fellows get confused when to clock, when to counterclock. I hope as you review those talks, you'll be able to recognize. But generally speaking, here a summary. For getting from radial innominate to the aortic valve, this is usually clock, as I explained here. This, it is usually clock. And left coronary engagement, as I explained last week, is more often clock than counterclock, but you have to react to what you see and be ready to change. RCA is a clock. Getting from the descending to the ascending aorta from a right radial axis is a counterclock, but confusingly, it is a clock from a left radial. It's the opposite. If you want to engage the subclavian to get into the lima or the innominate or the carotid from a femoral axis, it is counterclock. So those two are counterclock. A third one that is counterclock is engaging the vein graft to the right coronary artery, most often. Okay. Are there any questions about those ideas here? Okay, I will move on to next topic here. So this is an important idea, very common idea. We could not engage the right coronary artery in the standard fashion. We started at the valve, pulled with a clock, made our catheter look this way, basically, made our catheter look this way at various levels, and we could not engage the right coronary artery. What is your next thought? You always need to know that. It's extremely common. Don't try to engage the right coronary arteries if you don't know this idea. So the immediate next thought is what? Can somebody put the answer in the chat box? The immediate next thought is the right coronary artery is anterior, okay? So this is a standard right coronary artery. This is an axial cut across the aortic valve cusps. So the right coronary artery arises rightward. Now you have what we call anterior takeoff right coronary artery, which is still arising from the right cusp, except it's anterior right cusp, not the rightward right cusp. So this anterior right coronary artery poses engagement challenges. And here is why. We engage in LAO, which is orthogonal to the standard right coronary and left coronary artery origins. However, when the origin of the right coronary artery is anterior, LAO will be looking at it, okay? It will not be splaying it orthogonal to it. So in order to engage in anterior RCA, you don't make the catheter look this way anymore in an LAO view. You don't make it look this way in an LAO view. You have to make it look at you. You have to make it look at you in an LAO view. So that's one idea. But more importantly, the RAO view becomes more orthogonal to that orifice and is better to use to engage in that case, because RAO provides a better anteroposterior separation, whereas LAO provides a good right-left separation, okay? So what you do RAO view, so you fail to engage, pointing the catheter in this direction at multiple levels. One thing I would do is I would do a non-selective cusp injection like we did here to see where is that right coronary, and that will give you an idea. And when you do that non-selective puff injection, you can see where that RCA is originating here. It's originating in the middle anterior cusp. It's not originating from the right side of the cusp. So that's already your first hint. Two, you confirm that, then you do RAO view. This is RAO view, and you make your catheter aim anteriorly this way in an RAO view, okay? Orthogonal to the anterior wall of the aorta. So this is what was done here. So we went RAO in that same case, and we were able to engage it, aiming the catheter anteriorly. There is another tip. So the steps to do in that case, as I explained, one, you try to give non-selective right cusp angiography. Two, you do RAO view and you point the catheter anteriorly. Or if you do LAO, you have to make the catheter point at you, which is difficult to engage with the catheter pointing at you. And three, you need a catheter that reaches that anterior RCA, okay? Not the standard JR4 and Amplatz right 1 do not reach an anterior RCA, and here I'll explain why. Judkins right 4 is a short tip catheter. When you clock it and make it reach the right side of the aorta, it elongates and becomes eccentric, and it touches the aortic wall. However, when it's looking centrally, anteriorly, before it reaches the right side of the aorta, when it's looking centrally, it doesn't get elongated. You have to imagine those catheters in 3D, not in 2D. So when it's halfway clocked to look anteriorly, it's not going to touch the wall. You keep clocking it, it gets elongated in a 3D and it reaches that RCA. It doesn't reach the RCA when it's pointing centrally. That's why a JR4 or an AR1 do not reach that. You need a longer butt catheter like an AL1 or a longer tip like an AR2 to engage that anterior right. So that's why you don't just go RAO, you also change your catheter typically, okay? So very, very important, extremely common situation in RCA engagement. I would say it's maybe close to 5 to 10% of RCA. So really, you never try to engage in RCA not knowing this. I see people struggling trying to engage. Really, it should be a reflex to think of anterior RCA takeoff. So please ingrain this in your brains. This is another example. Again, what can you tell about that right coronary artery? This is an LAO view. The catheter is on my left hand compared to the spine. So this is an LAO view. And the catheter is looking at me as it's engaging that RCA. Again, this is an anterior RCA takeoff, okay? you need AR2 or AL1. Okay. Any questions regarding this topic? So I will move to another very important idea that we encounter often. So as I said, when you engage the right coronary artery, you have to pull and clock. So you need a lot of clocking maneuvers, and sometimes you counterclock and reclock. So a lot of torque is involved. So in a patient with innominate tortuosity, subclavian tortuosity, or a sharp innominate aortic angle, it is hard to transmit that tortuosity, particularly when you have that sharp and calcified angle. There will be some inability to transmit any of the clockwise torque for RCA engagement, okay? So this is such patient where we were not able to transmit any torque to engage the RCA. So here is what you did. So one technique to improve your torque is to torque with a wire in place. So you keep that 0.35-inch wire that we use to advance our catheters, and we torque while the wire in place. And here's what happened. We were able, with a lot of difficulty, even with the wire in place, we were able to transmit our clockwise torque and engage the right coronary. And you see here, it engaged the right coronary. Now, why does this work? For a couple of reasons. The wire does a couple of things. One, it provides stiffness to the catheter, which allows, and it provides more body and weight to the catheter, which allows more torque transmission. Two, it straightens that angle here. It straightens it so, and it straightens the tortuosity, which again allows more torque transmission. However, here is what happened. After we engaged that coronary, we took the wire out, and look what happened. The catheter flew up after we took the wire out. The catheter flew away. Why? Because that tortuosity that was straightened now went back to its original shape. Okay? So here's the message here. Those are cases sometimes that are so difficult that you have to engage and take your images while the wire is still in place. You don't take the wire out. But how can you do that? You cannot usually image with an 0.35-inch wire in place because it plugs the hole of that catheter. So those are cases where we engage while keeping an 0.18-inch wire in place. So here is what we do. And this is what was done in this case. So we have the catheter, we put through it, rather than the standard 0.35-inch, we put through it an 0.18-inch peripheral wire, a stiff one, like something like V18 or SV5 wire. And we use a TUI. It's a device that allows you to advance and put a wire in one place while keeping hemostasis with a valve, and connect the manifold and inject contrast through another hole. Okay, so we engage this, transmit our torque with a wire in place, and then we inject and take our images while the wire is still in place. And this is what was done here eventually. After the catheter pulled out with taking the 0.35-inch wire, we redid everything with an 0.18-inch, and we imaged with an 0.18-inch wire. There is another key advantage of this. I said the wire straightens the catheter, straightens the tortuosity, and allows you to transmit your torque. It does a third very important thing. Anybody knows what's the risk really? What's the big risk when you keep torquing, and not transmitting the torque? Whenever you're doing this in a difficult case with a lot of tortuosity, you keep torquing, not much gets transmitted. You need to have one worry, one big worry as you're doing this. Anybody can tell me what is this big worry that you need to have?
I think you can like twist the catheter so there's a kink, or maybe it can partially fracture.
Excellent. Yes, catheter kink. You should be obsessed with that. And what's your hint to that? As you're clocking, you're obsessed with this. And how do you know I'm starting to kink that catheter? Well, one, I would say, when you're seeing that you're torquing a lot and it's not transmitted, stop. Get the wire and do this maneuver. Don't wait for the kink to happen. So know this technique. Now, if it does happen, excellent answer, you lose the pressure tracing. So you really don't want this to happen. So if you keep torquing in place and the torque doesn't get transmitted, your pressure gets lost. It may dampen or become very funny, but honestly, in my experience, when the catheter kink, you just lose the pressure. Your screen becomes empty. You don't have any pressure tracing anymore. It's totally lost. So that's your early hint. And please don't keep torquing when this happens, because this is what happened. You eventually get not just a kink, you get a knot. Look at this. You see, this is a knot here. And that becomes very hard to take out. So always a reflex. If you're torquing a lot, be obsessed. I may kink that catheter, and watch your pressure tracing. But more importantly, don't let this happen. Put a wire in place and engage with a wire in place. Okay? So those are extremely important ideas that we encounter often. This is another case here. We were going left radial. I did this yesterday. We were going left radial through a lot of subclavian tortuosity in a patient with grafts. And we were trying to engage left OM and diagonal grafts. Those are difficult to engage. So through this tortuosity, it was hard to transmit the torque, but we were able to engage successfully both grafts with an 0.18-inch wire in place using an Amplatz left, my favorite catheter for difficult cases, Amplatz left 1 in this case. All right. Any questions here? I will move on to describe another idea. This one is less common, but you need to know it. So we try to engage the right coronary artery with the Judkins right 4, looking to the right surface of the aorta with no success. We try to engage the RCA with the Amplatz left 1, looking to the anterior surface of the aorta using REO view with no success. So we followed the standard steps. We gave non-selective puff injections of that cusp, and we did not see the right coronary artery. So what is the next thought here? So the next step is what I just described, is you need to give non-selective puffs, do a cusp injection, a right cusp injection, and try to see where is the right coronary originating. Where we did that and we could not see it. So where is it? What is the next thought? And you answered correctly. You should think, well, the RCA is not rightward, it's not right anterior, it's purely left originating. And you'll see that it's in about 1.5 to 2 per 1,000, the frequency of that. So if you do enough cases, you'll definitely see that. And you need to know this idea. So after you fail trying those, you should think of left arising. Well, do a cusp injection to make sure you're not maneuvering incorrectly and missing a right cusp origin of the RCA. Then if the cusp injection doesn't show anything, think it's left originating RCA. Okay? And in that case, the way I would engage it, the Amplatz left can work to engage it, except you need to know to look toward the left cusp. You need to maneuver your catheter from the left cusp. So you can use the Amplatz left, which is used to engage this. You may use it here, except you need, rather than Amplatz left 1, you may need Amplatz left 2. But you can also use the Judkins left catheters, the Judkins left that are used for the left coronary artery. So this is a case where we knew that the RCA is originating from the left cusp. So we tried to engage it using the JL 3.5, which was used to engage the left coronary. It couldn't engage it properly, but you can see the origin here. It's a little higher from the left coronary origin. So what we did here is we engaged it successfully with a JL3, smaller JL. And that's often the case. Smaller Judkins left is successful in engaging a left arising right coronary artery, a left cusp arising right coronary artery. And this is an illustration of that. So there are, I won't dive into the details. I have another talk about anomalous coronaries, but left arising right coronary artery can have multiple origins. It could be somewhat this way, and this is usually successfully engaged, that C with an Amplatz left. Those closer to the left coronary artery can be engaged with an Amplatz left, but if you choose a Judkins left, usually you need a Judkins left that is shorter than the Judkins left used to engage the left coronary artery. So you often need a Judkins left 3, and you make it loop up for A or elongate down for B. Okay. So I hope you got this in your idea, in your brains as well. This is a very important idea. Okay. Any questions? Another idea before I move on to the guiding catheters is this, also very common. All the ideas I've described so far, except the left arising RCA, are very common ideas. So another very common idea is this. You're engaging the right coronary artery using Judkins right, or even more commonly, this happens with a Tiger catheter. So you're engaging, the catheter is looking like this, and this is what happens on your pressure recording. You remember, as you're engaging, you're always looking at your pressure recording. So that pressure damped. What's your immediate next thought? So the catheter is damped. That means that this catheter is wedging the coronary artery. It could be that you're engaging a very small or diseased ostial RCA. That's one thought. But the most common thought, whenever the catheter is looking like this, looking upward and looking a little anterior, meaning it's not spread all the way to the right. So looking upward and not spread all the way to the right, your immediate thought when you see this is, yes, you're in the conus branch. Conus branch being a small, early arising branch of the RCA, and it's not infrequent that the catheter goes into it. This is how the conus branch is. It is smaller, but it's also more anterior and more upward looking. So if your catheter is shaped in a way that it's looking upward, it's not unusual for it to engage that conus and cause that damping. You absolutely do not want to inject dye here. If you inject dye while this is damping, you'll cause, this is an occluded conus. The catheter is occluding that conus. So the dye will stain, will hang around, will not clear. It will cause myocardial stain and subsequently ventricular fibrillation. So you will definitely cause ventricular fibrillation if you inject while in the conus. Now, if you inject while in the conus, you know, you didn't recognize this, you didn't pay attention, you inject and you see the conus and the dye staining in it, you don't have VFib yet, your immediate reflex is to just pull out that catheter and let that dye clear before you get VFib. So it's okay if the mistake happens, but don't sit on it. You see the dye staining in the conus, immediately pull out your catheter before VFib happens. VFib will happen in the next 3 seconds if you don't react quickly. So recognize this tracing, recognize what you do when you inject puff into that damped conus engagement, okay? So let's say, what do you do here? So you recognize you're in the conus, you did not inject dye. So what do you do to correct that? In order to correct that, you want the catheter to not be pointing up and anterior. So one thing to do, if the catheter is not too deep, as is the case sometimes with the Judkins right 4, you can keep clocking that catheter. So it goes from the conus, which is more anterior. So the conus is somewhat here. So if you keep clocking the catheter, you'll go from the conus to the RCA. So you can keep clocking that conus to go into the RCA. And you'll often see that catheter, as you keep clocking it, you'll see the catheter fall down. That's one idea. And typically you keep clocking while pulling a little bit to make that catheter point down. Another idea, if the catheter is too deep in the conus and when you clock, you're not moving much, what you need to do, you need to counterclock to disengage, then try to engage again while pulling on the catheter, pulling more on the catheter to elongate it and make the tip point down. For the beginners, if it is hard for you to do this maneuver, to disengage and re-engage while pulling on the catheter to make it look down, one technique that works is just get a catheter that points down. So if you're using Tiger catheter, which points too much up, change to Judkins right 4. If you're using Judkins right 4, change to AR1 or Judkins right 5, which I rarely use, but it can be used in those cases. It points more down. Okay? So extremely important, very common scenario. We see that every single day almost. So I hope all those ideas are ingrained in your brain. Please watch those again, because they will save you, I think, a lot of trouble. Okay. If there are no questions, I will move to the next topic here, which is how to maneuver Amplatz left, engagement and disengagement. And I will also describe some other guiding catheters. So my favorite, believe it or not, my favorite right coronary artery guide from a transradial access is an Amplatz left. Okay, this is my standard catheter. So it's a very important catheter. It's also a very important catheter in graft and in left coronary engagement and in all complex coronary interventions. And this is where you can see in my figure of what catheters to use, you can see I put the Amplatz left on a separate area because it can be used for everything. Typically, we use Amplatz left 2 for left coronary artery and Amplatz left 0.75 to 1 for right coronary artery. Typically, I use Amplatz left 1 from radial RCA engagement, 0.75 from femoral RCA engagement. Okay. So I will explain how to maneuver it. One, how is the catheter looking? As I described, it's a catheter that is duck-shaped with a big butt that sits on the aortic valve and the opposite aorta. That's what makes it so special, that support it gets from the aortic valve and the opposite aortic wall. And this is how we maneuver it. Let's say we want to engage the left coronary artery. We typically use for left coronary a longer AL, AL2. So standard maneuver, get the Amplatz left in an elongated fashion. You don't want it to reach this early on. You want it early on to be elongated with a free tip. So you make the elongated catheter with a free tip, typically reach the cusp of interest. Not always, but typically, especially for left coronary engagement, you want it to reach the cusp of interest. So you make that tip on that cusp of interest. But very important, you want to make sure that tip is free. So you get it there, you pull a little bit to make sure the tip is free. Then you start to torque and push to shape it into a duck. Usually for left coronary, either clock or counterclock can work. So you torque, you push and torque it. And you want to hook the coronary as the duck is being shaped. You don't want, once your duck is fully shaped and looking upward like this often means when you see the shape that you already missed the coronary. The coronary is already below you and you missed it. And you need to pull this catheter, make it elongate again, and start over. So you want to engage that coronary as the duck is shaped. Don't keep pushing if you haven't engaged in this position. You'll end up too high, okay? So this is an illustration of a case. This is an Amplatz left 2 that we use to engage a left coronary. This is a patient with a large aorta in the 5 centimeter range. So look at this. So we hooked the tip in the left coronary, then got it free, then kept pushing it to try to reach. But what can you tell here? I'm imagining those cusps in my brain as I do during all my engagements. So what can you do here? We did a puff and we were way below the coronary. So this was an Amplatz left 2 in a big aorta. You need a bigger Amplatz left. So you need an Amplatz left 3 for this. Amplatz left, as opposed to Judkins left, the bigger it is, the more it points up. So here you want it to point more up. We needed a bigger Amplatz left 3 to engage. But this is the maneuver. We got it on the cusp. We got it free. Then we pushed with a slight torque to get into the coronary. I will show you more cases. I have several cases showing how, illustrating how to use the Amplatz left to engage. So this is Amplatz left 1 used to engage the right coronary artery. The catheter tip is elongated and the tip is hooked on the left cusp. Okay, so the fellow here tried to maneuver it, tried to get the tip in the right cusp, which is appropriate. So he did the clock, then after clocking, push it down to get into the left cusp and the right cusp, then pushed all the way to shape it. That's a good maneuver. It can work. So we got into the right cusp. Then after getting in the right cusp, pushed it to make it look into the right coronary. Look at it again. That can work, except that I think he came too high. You know, the idea, it's always nice to, you know, you want to engage the right coronary, you want it to be elongated, and you're clocking and pushing as you're engaging. You know, I think the problem here, he probably clocked and got it a duck shape too early. So this was a better maneuver on that same patient. This is what worked best. We actually tried here to clock and shape it from the left, which is okay. And that worked more successful. That was more successful here. So from the left cusp, we got the tip free. Then we started to push and clockwise torque while the tip is free, and we got it to engage that right coronary. That was more successful here. But this was also, you know, this is a good maneuver as well, to try to get the tip in the right cusp, but get it free, and try, after you get in the right cusp, try to get it elongated and the tip onto the cusp before you start clocking and pushing. Okay, I think maybe here the clock and push was a little too high. This is another illustration of AL1 used to engage the right coronary artery. Again, I use this catheter often in all my right coronary interventions. So first, get the Amplatz left to be elongated with a free tip on the aortic valve, as we did here. So we elongated it and get it free tip. You see, it's a nice free tip. Then we pushed and clocked it. And we got onto, so free tip, then we pushed as we're clocking, and we got into the right coronary artery. Those are the three key words: elongated with a free tip on the aortic valve, then you start torquing and pushing. It's an important idea is, again, you don't want it to become fully duck-shaped and looking up before it's engaged. If it is fully duck-shaped and looking up like this, and it's not in the coronary, it's way too high. You need to restart over, elongated, make it look down with the tip free, then clock and push. This is another illustration here. Again, it's good maneuver. Here it started from the left cusp. So the catheter tip here, you can see at the very beginning, the catheter jumped from right to left cusp. So that's okay. He tried to, the catheter was elongated and free. So he tried to push while torquing. This is a good maneuver, except he came too high. And a lot of time when you try from the left cusp, you may come too high. It's okay to try from a left cusp, but it happens that one can come too high. So what we did here, I directed the catheter tip when the AL was elongated. I directed the catheter tip into the right cusp, pushed it down while it's elongated, then pushed the whole system and clocked it. And I came lower than what happened in this case here on the left-hand side. And so we were able to engage it. Notice here that the catheter is less duck-shaped than it is here. And again, I find it more successful to engage when the catheter is not fully duck-shaped. It's fully duck-shaped and looking up, it's often too high, and you need to restart over. And the beauty about Amplatz left is that you can shape it. Like you can pull on it to make it dive more down, or you can push on it to make it more duck-shaped and point up. This is a downward-looking RCA, but I use an Amplatz left, even though Amplatz left tend to point up, but if you maneuver it properly, that Amplatz left can be pointing down, can point down, if you pull on it and make it look down. I will show another case. This is different now. This is Amplatz left to engage the vein graft. Usually to engage a vein graft, you need, depending on the aorta, Amplatz left 1 to 2. It depends on the case. Often I use 1.5 if you have it in your lab. So this is here Amplatz left 2 used to engage a vein graft to an obtuse marginal. So this is how we do it. Again, we get the catheter elongated with a free tip. Just to give you an idea, this is the ostium. Here we have a marker. This is the ostium of the vein graft. So it made things easier. But even if you don't have a marker, you get the tip of that Amplatz left to be free and the Amplatz left to be elongated. Then you hook that free tip onto the ostium. And after you hook it, you push to make it point a little up and to create that duck shape or the semi-duck shape. And this is what happened here. And we got very good support. Okay. Another idea, very important idea, is how to disengage the Amplatz left. The problem with the Amplatz left, it gives very good support, but as you pull it, it has two risks. One, it can engage deeply, as you can see here. As we engage, we push, it can go deeply, and that can create a dissection if you're not careful with your manipulations. Okay, imagine here, you can go deeply in that coronary, especially if you pull that catheter. If you pull it, it will dive deeper, which will give you more support, but can dissect. So that's the problem with Amplatz left. It can go deep in the coronary as you pull it and dissect. Second, it can dissect as you're trying to take it out. If you're inadvertently pulling it out by just pulling it, this is what happens. So this is the Amplatz left guide engaging the coronary, left coronary in this case. So if you just pull it to disengage, what happens when you pull? You actually dive it deeper. You shouldn't do that. Actually, we use the pulling maneuver to get further support and to more deeply engage an Amplatz left. So pulling is used to get deeper and deeper support with Amplatz left. It's not used to disengage. So be careful. A catheter that is coaxial and well engaged in the coronary Amplatz left should not be just pulled to disengage. In those cases, what you need to do, you should actually push the catheter, push it, because push will make that catheter point more up and flip out of the coronary ostium. And this is here an illustration of that. So this is a guide inside the coronary. Initially, we tried briefly to pull to see how it reacts, and you can see it dove deeper. Here we pulled, and it dove deeper. So what we did, we immediately changed. So we started to push. We started to push, and as we're pushing, you see the catheter tip was starting to come out. And here we pushed furthermore, and we torqued it. So usually we keep pushing, and when the catheter is close to coming out, you torque it, whether clock and counterclock, and it will flip totally out. So see how by keep pushing it, we made it very duck-shaped, and we were able to push it out of the coronary. So push is what works. But you have to do it under fluoro, and you react to what you see. Sometimes pulling works. And this is a case where pulling the catheter just works. And you need to know, when does pulling work? When the catheter tip is not deep, unlike here. Here, the catheter tip was deep. If you pull it, you will dive deeper. But when the catheter tip is not deep and the catheter is not coaxial, as is this case here, the catheter tip wasn't deep in the coronary and the catheter was not coaxial. It wasn't duck-shaped here already. You know, it almost looked like a hockey stick catheter or a multi-purpose. So when it's not deep and not coaxial, you can just try to pull it under fluoro. And this is what was done here. Another tip is, you know, we have the wire here in place. This was an intervention, and the balloon. Another idea is to try to disengage an Amplatz with a balloon at the tip of the deflated balloon at the tip of the catheter. Advance it a little bit at the tip of the catheter, and that will serve like a dilator. It will smoothen the edges and also reduce the chance of dissection as you're disengaging Amplatz left guide after an intervention. Okay. I will move to the last section, which is a quick description of the other guiding catheter for the RCA that we can use from radial access. So to me, Judkin's right 4 is an absolute no for RCA. It tends to be extremely unstable. It flies in and out of the right coronary. Okay, it's like floating in the air. It's just not going to be stable. So I suggest you don't use it. Any breath the patient takes, that catheter will go all the way up and will pull all your devices. So do not use it. I almost never use it as a guide. I use it as a diagnostic, but never as a guide. So I use AL1, but I also use Ikari right and Ikari left. I described Ikari left last time. as a good guide for left coronary engagement. But like Amplatz left, Ikari left can be used and is a great guide for the right coronary as well. It's a universal catheter. And the beauty is that it's usually the same size for left coronary and right coronary. Unlike Amplatz left, you need bigger Amplatz left for the left coronary than the right coronary. Ikari left is usually the same size. So I like it in STEMI, inferior STEMI. It's definitely my favorite catheter. And I'm not sure whether the RCA or the circumflex is the culprit. So I go with the Ikari left and I take pictures of both sides, and whichever is the culprit, I intervene with that same guide. Okay. So Amplatz left, and it can be positioned like this, or it can be positioned deeper in a power position. If you further clock it, it will go deeper. So I'll describe those catheters a little more. So those are the guiding catheter for the right coronary artery. Again, not Judkins right. So we have Amplatz left one, we have Ikari left, and we have Ikari right. Ikari right, if you want to compare it to something, it's somewhat similar to the Amplatz left. It tends to be an aggressive guide with a long tip, and it comes in 1 and 1.5 size. 1.5 is a kind of an aggressive guide. I suggest, if you're not familiar with this guide, start first using Ikari right 1, then progress to Ikari right 1.5. Okay, 1.5 has a longer tip, more support, deeper, but more dissections. So this is the shape of those catheter in the coronary. This is the Amplatz left. This is the Ikari left 3.5. And it's providing support. It doesn't often sit on the opposite aortic wall. It's kind of like a Judkins right, except it's more deep-seated and more stable. So it provides support by deep seating, not by opposite aortic wall. So it's kind of like a very good Judkins right. Conversely, Ikari right is somewhat similar to Amplatz left. It sits usually on the aortic valve and on the opposite aortic wall, and it goes deeply in. So those are somewhat similar. This one is a better Judkins right. This is an illustration. Usually all those catheters, the more you clock them, the more deeply they go. If you want to get a right coronary guide deeper, people think you need to push and push basically. But that's not always the case. As I explained, with Amplatz left, pulling can get the guide deeper. With Ikari, with the Judkins right, and with Ikari right and left, usually clocking more can get the guide deeper. So you have to react to how your catheter is shaping. A lot of time, clock gets your catheter in, counterclock gets it out. Like when you're doing ostial stenting, you clock to get in, you counterclock to disengage and put your stent in. This is a case of an Ikari right 1.5. Deep-seated. This is what can happen. I want to show you that. It created a dissection. It's an aggressive guide, so be careful with it. When you're deep-seated in a power position with Ikari right and with Amplatz left, you can create a dissection. This is in the same patient, Ikari right 1. This was Ikari right 1.5 deep-seated. This is Ikari right 1, not deep-seated, much less aggressive. You can control those catheters. Again, if you don't clock them too much, you won't get too deep. If you don't pull them, you don't get too deep. So you can control it. And early on, you may not need to go that deep, especially early on in your intervention. As you need more support, you can try to get it deeper. This is another case of Ikari right 1.5. You can see how sitting on the aortic wall and close to the aortic valve, almost like an Amplatz, and it is deep-seated. Very good support. Ikari right 1.5, again, risk of dissection. This is another case here. This is a power position of Ikari left. This is a standard position of Ikari left when you use it to engage the right coronary artery. But Ikari left, the beauty of it, you can get it in a benign shape, but you can get it in a more aggressive shape. By pushing it and clocking it furthermore. You can get it almost like an Ikari right. And that's another reason I like the Ikari left. I can use it more aggressively or less aggressively, depending on how much support I need. To a degree, if you're good with the Ikari right, you can do the same. You can get the Ikari right, especially Ikari right 1, to not be too deep. And you can maneuver it to get it deeper with further clock and pull. So to summarize RCA guide, not the Judkins right in my position. Amplatz left 0.75 to 1 is my favorite. I carry left or I carry right are second favorite, one being less aggressive and less risky with the I carry right. And those can be used in power position, especially I carry left. You can use it in power position or in less power position for less risk. Now for ostial RCA PCI, keep in mind, you cannot use those aggressive deep-seated guides for ostial RCA. So what is my favorite guide for ostial RCA? Again, I don't like GR4 because it will be floating up and down and it can pull your stent and misposition your stent as you're trying to position it. So I would not use a GR4 even for ostial RCA. I use AR2, which is more stable. That's one guide I use for ostial RCA, but I can also use an Amplatz left, something like this, where I control it and I don't pull it and prevent it from getting too deep, something like this. So you can get an Amplatz left if you're good at it and if you can control it. You can also use an I carry left, not in a power position, and an I carry right one, not in a power position. So those also can be used. But for somebody who's new, doesn't want to make his life difficult, Amplatz right 2 is probably the best guide for ostial RCA. Any questions?